Okay, so imagine this. A condition affecting how we process, well, protein. Sounds complicated, maybe.
Mm-hmm.
But there's this routine test, the newborn screening, that tiny heel prick.
Yeah, the Guthrie test, or, well, the modern equivalent.
Right, and it catches this condition nearly every time. It completely changes lives because if it's missed, well, the consequences can be quite serious, especially neurologically.
Exactly. We're diving deep into phenylketonuria today. PKU. It's a really fascinating example of how understanding one specific metabolic pathway and intervening early, it just has this huge impact.
So the mission for you listening is basically to walk away from this with a really solid grip on PKU.
Yeah.
Think of it as your, audio revision guide. We'll hit everything: definition, causes, management, complications.
We'll throw in some memory aids, too. Hopefully make it stick.
We're pulling all this from some pretty detailed revision notes covering, well, everything TKU.
All the key stuff you need.
And the idea is to give you that high-yield understanding without you having to, sift through loads of text. Save you some time.
Let's get started then.
Perfect. So what exactly is phenylketonuria? Let's start there.
Okay. So PKU, phenylketonuria, it's fundamentally a rare genetic condition, inherited.
Right.
The body basically struggles. It can't properly break down an amino acid called phenylalanine.
Phenylalanine. Oh.
And that's because of a deficiency or sometimes a complete lack of a really crucial enzyme. Phenylalanine hydroxylase. We just call it PAH usually.
PAH. Got it. So if that enzyme, PAH, isn't doing its job, what happens?
Well, phenylalanine, it's in lots of foods, especially high-protein ones. When the PAH enzyme isn't working right, this phenylalanine, it just builds up, accumulates in the blood.
Yeah.
And if those levels stay high untreated, that's when we see the problems. It can cause significant issues with brain development, neurodevelopmental problems.
Brain development, that sounds, very concerning. Is there a quick way, like a mnemonic, to remember the core issue?
Yeah, we can try one. How about PKU? Poor kids metabolize unsuccessfully.
Poor kids metabolize unsuccessfully.
It links PKU, the P and K, to that idea of poor unsuccessful metabolism because of the PAH enzyme problem, leading to that buildup. Just a little hook.
I like it. Poor kids metabolize unsuccessfully. Catchy enough. Okay, so why does this enzyme deficiency actually happen? What's the etiology, the underlying cause?
It's genetic, purely genetic. It follows what we call an autosomal recessive inheritance pattern.
Autosomal recessive. Remind me.
It means you need to inherit 2 copies of the salty gene, one from each parent, to actually have the condition.
Ah, right.
The parents are usually carriers. They have one faulty copy and one normal one, so they don't typically have PKU themselves.
Yeah.
But they can pass that faulty copy on.
So the main issue is a mutation in the gene for the PAH enzyme.
Exactly. That gene sits on chromosome 12. A mutation there means the body either makes less PAH enzyme or none at all, or maybe an enzyme that just doesn't work properly.
Okay.
Although, there's a less common scenario. Sometimes the PAH enzyme itself is fine, but a helper molecule, a cofactor called tetrahydrobiopterin, or THB.
THB.
Yeah, THB. Helps PAH do its job. If there's a deficiency in THB, that can also lead to high phenylalanine levels, even if the main enzyme is okay.
Ah, so it's not always the enzyme directly. And you mentioned genetics. Is it complex? Are there lots of variation?
Oh, definitely. There's huge variation. Scientists have identified over 950 different mutations in the PAH gene.
Wow, okay.
And this genetic diversity means PKU isn't just one single thing. We usually classify it. Type I, or classical PKU, that's the most common and severe form.
Right.
Autosomal recessive, very little or no PAH activity.
Right.
Then there's type 2, where there's still some enzyme activity left. It's often milder.
Milder.
And then there's what's sometimes called malignant PKU. That's the one caused by the THB cofactor deficiency we just mentioned. The management could be a bit different for that one.
Okay, those distinctions are helpful. Now, thinking about who's more likely to get it, what are the main risk factors?
Well, the biggest one, as you'd expect with a genetic condition, is family history. If PKU runs in the family, or if parents know they're carriers.
Then the risk is higher.
Exactly. And we also see it more often in certain ethnic populations. It's more prevalent in people with Northern European ancestry, for instance, and also in Turkish populations.
Interesting. So ancestry plays a part. Okay, let's get into the nitty-gritty, the pathophysiology. What's actually happening inside the body?
So we've established the core problem.
Yeah.
Low or zero activity of that PAH enzyme.
Right.
Consequence. Phenylalanine builds up in the blood. way higher than it should be.
And how does that buildup actually cause the harm, especially to the brain?
Yeah, that's the critical part. High levels of phenylalanine are, simply put, neurotoxic.
Toxic to the brain.
Yes, especially the developing brain in babies and young children. It interferes with normal brain development, affects neurotransmitter function, those chemical messengers the brain cells use to communicate. And over time, untreated, this leads to intellectual disability.
Oh.
Plus, the body tries to get rid of the excess phenylalanine by converting it into other things, like fetal pyruvic acid.
Right.
And some of those breakdown products are also toxic to the brain. So it's a bit of a double hit.
The phenylalanine itself and its byproducts. Got it. Now, if that newborn screening test flags high phenylalanine, does it always mean PKU? What else could be going on? The differential diagnosis.
That's a really important question. No, high phenylalanine doesn't automatically equal classic PKU. There are other things to consider.
Like what?
Well, you could have that milder form, type 2 PKU, sometimes just called hyperphenylanemia or HPA. There's still some enzyme function there.
Okay.
You definitely need to rule out the THB deficiency, the malignant PKU, because the treatment's different. You might need to supplement THB.
Right, the cofactor issue.
Exactly. Then there are other completely different metabolic disorders that affect amino acids like tyrosinemia, type IN2. Those need considering. And sometimes, though less common, liver disease in an infant or child could potentially affect amino acid levels.
And you mentioned something about pregnancy earlier?
Yes, maternal PKU. This is crucial. If a mother has PKU and her phenylalanine levels aren't controlled during pregnancy.
So her levels are high.
Her levels, yes. The baby's exposed to those high levels in the room. Even if the baby doesn't inherit PKU itself, that exposure can cause serious problems for the baby's development. Microcephaly, heart defects, intellectual disability.
Wow, okay. So that's distinct from the baby having PKU.
Absolutely. And then, you'd think about other rare metabolic conditions, maybe maple syrup urine disease, though presentation is usually different. And of course, you need to differentiate PKU from other causes of general intellectual disability or developmental delay, which could be genetic or environmental.
It's clearly not always straightforward, needs careful investigation. So how common is PKU? What's the epidemiology look like, say, in the UK?
In the UK, the estimates vary a bit, but it's roughly somewhere between 1 in 10,000 and 1 in 20,000 newborns.
1 in 10 to 20,000. Okay.
But what's interesting is the variation among different ethnic groups within the UK. We mentioned higher prevalence in Turkish communities and also Yemenite Jewish. Some European groups, Italian and Chinese populations living here, tend to have higher rates compared to, say, the white British or black populations.
Do we have specific figures for that?
Yeah, there's some data. For example, from Southeast England, the incidence per 10,000 live birth was about 1.14 for white infants, but much lower, 0.11 for black infants, and intermediate, 0.29 for Asian infants in that study.
That's quite a difference.
It is. And globally, Turkey has a very high incidence, maybe 1 in 2,600. It's also higher in places like Ireland, parts of Eastern Europe, Italy, China, compared to, say, Finland or Japan, where it's much rarer.
And it feels like the newborn screening has completely changed the landscape for PKU.
Oh, absolutely transform it. Before routine screening, PKU was a major cause of preventable intellectual disability. Now, with early detection,
you can intervene straight away.
Exactly. Intervene with the diet, prevent that buildup, and drastically reduce the risk of severe neurological problems. But it's a good point. If you encounter an older individual, maybe born before screening was universal, who has unexplained developmental delay or learning disabilities,
you should still think about PKU.
It should still be on the list of possibilities, yes, especially if they have some of the other features.
Right. So what are those clinical features? If it's missed at birth, what signs and symptoms might appear?
Well, that's the tricky part. Newborns usually look completely normal at birth. That's why the screening is so vital. Okay.
Symptoms
develop gradually as phenylalanine accumulates, if it's not treated. But sometimes certain physical traits might become apparent. Classically, children with untreated PKU often have fairer skin, lighter hair, blonde, and blue eyes compared to their siblings or parents, due to effects on melanin production.
Ah, interesting. And developmentally.
That's where the main problems emerge. Progressive developmental delay is a hallmark. It might become noticeable around, say, 6 months old. Delays in hitting milestones, sitting up, crawling, walking, talking. Learning difficulties become apparent as they get older. Neurologically, seizures can occur, sometimes infantile spasms in babies.
Okay.
Skin-wise, eczema seems to be more common in individuals with PKU.
And I think I read something about a specific smell.
Yes, that's quite characteristic, though maybe not always obvious. A musty or mousy odor, it can be in the urine, sometimes sweat or breath. It's due to the buildup of phenylacetic acid, one of those byproducts.
Right, the byproduct thing again. Any behavioral issues?
Yes, behavioral problems are common too.
You're right.
Things like hyperactivity, irritability, short attention span. Sometimes autistic features can be seen in untreated or poorly treated individuals.
Well, what if someone, maybe an older child or adult, wasn't treated or stopped treatment? What does that look like?
In untreated older children or adults or those who stop the diet, the picture could be more severe. You might see things like recurrent vomiting, maybe those skin eruptions again. The odor might be more noticeable, more severe behavioral disturbances, sometimes even things like self-mutilation, profound hyperactivity, maybe with repetitive movements, rocking, hand flapping.
That sounds very difficult.
It is. And importantly, even in individuals who were treated early but then stopped the diet later in life, maybe as teenagers or adults,
Yeah.
they can experience a decline, a drop in IQ, sometimes quite significantly, maybe 10 points or more. Problems with executive function, attention, processing speed. Motor skills can decline too, and MRI scans of the brain might actually show changes, like demyelination damage to the nerve coverings.
It really underlines how vital lifelong management, or at least ongoing monitoring, is.
Absolutely crucial.
So how do we actually confirm the diagnosis? What investigations are key?
The absolute cornerstone is the newborn blood spot screening, that heel prick test.
The Guthrie test again.
Well, the method's changed, but the principles are the same, done usually between day 5 and day 9 of life. It measures the phenylalanine level in that dried blood spot. Some places might also check for phenylpyruvic acid in urine, but the blood spot test is key.
Okay. And if that initial screen is positive, shows high phenylalanine.
Then it needs urgent follow-up. It doesn't automatically mean PKU, as we said, could be transient, so repeat blood tests are essential, usually plasma amino acid analysis.
And what level confirms it? Is there a threshold?
Generally, a plasma phenylalanine level consistently above 120 micromoles per liter, the MUNOL, is suggestive of PKU or hyperphenylanemia requiring management, though the exact cutoffs for initiating treatment can vary slightly.
Okay.
And then specialist investigations are needed to figure out the exact type. That involves measuring tyrosine levels, often low in classic PKU, and doing tests to check tetrahydrobiopterin, THB metabolism, to rule out PHB deficiency.
Right, distinguishing between the different types.
Exactly.
What if you suspect it in an older child who missed screening?
For an older child presenting with, say, developmental delay, you do plasma amino acid analysis. Urine amino acid screening, or organic acid analysis, can also be helpful to look for those characteristic byproducts.
And genetic testing.
Oh, yes. Molecular genetic testing is very important now.
Mm-hmm.
Analyzing the PAH gene, or the genes involved in PHB synthesis or recycling, if that's suspected. It confirms the diagnosis, can sometimes predict severity or responsiveness to treatment like THB,
Mm-hmm.
and it's crucial for genetic counseling for the family, carrier testing for relatives, and potentially prenatal diagnosis in future pregnancies if desired.
And once diagnosed, are there ongoing tests?
Constantly. Nutritional monitoring is vital. Regular blood tests to check phenylalanine levels are essential, maybe weekly or biweekly in infants, less often as they get older. But lifelong monitoring is needed to adjust the diet. Monitoring intake of other nutrients is also key.
Okay.
And sometimes, as we mentioned, if a treated child's condition unexpectedly worsens, brain MRI scans might be used to look for any structural changes or signs of demyelination.
So a mix of screening, blood tests, sometimes genetics, and lots of ongoing monitoring. Makes sense. Let's talk management. How is PKU treated?
Right. The absolute mainstay, the cornerstone of management, is the diet. A strict, lifelong phenylalanine-restricted diet.
Lifelong.
Ideally, yes. While some guidelines used to suggest relaxing it in adulthood, the evidence now strongly supports maintaining dietary control lifelong for best outcomes, especially cognitive function.
Okay. So what does this diet actually involve? It sounds tough.
It is very challenging, no doubt. It means drastically limiting intake of high-protein foods. Meat, fish, chicken, eggs, dairy, cheese, nuts, seeds, legumes. All very high in phenylalanine.
So what do they eat for protein?
They rely on special medical foods, phenylalanine-free infant formulas, and then later, protein substitutes or medical formulas for older children and adults. These provide the necessary amino acids, vitamins, and minerals without the phenylalanine. They can have carefully measured amounts of certain low-protein natural foods, like some fruits, vegetables, special low-protein breads, and pastas. But everything has to be carefully calculated and monitored.
Constant vigilance.
Absolutely. Regular blood tests guide the dietary adjustments. And they absolutely must avoid the artificial sweetener aspartame
Why aspartame?
because it's metabolized into phenylalanine in the body. So it's hidden phenylalanine. It's in lots of diet drinks and foods.
Right. Need to check labels carefully. Any supplements needed?
Often, yes.
Oh.
Because the diet is so restricted, they might need supplements for things like iron, vitamin B12, calcium, vitamin D, and tyrosine, the amino acid that phenylalanine normally gets converted into by the PAH enzyme, often needs to be supplemented because they're not making enough of it.
Makes sense. It sounds like a huge commitment for the individual and their family.
It really is. Needs specialist dietetic support right from diagnosis through weaning, childhood, adolescence, adulthood, lifelong support.
Is there anything beyond diet? Any medications?
Yes, there is one pharmacological option for some patients. Sapropterin dihydrochloride. Remember THB, the cofactor.
Yeah, the helper molecule.
Sapropterin is a synthetic form of THB. And some people with PKU, whose mutations mean they have some residual PAH enzyme activity, giving them extra THB can help that remaining enzyme work better.
So it boosts the faulty enzyme.
Essentially, yes. It can help lower blood phenylalanine levels, and in some responsive individuals, it might allow them to tolerate a bit more natural protein in their diet.
Who gets this?
It's not for everyone. You need specific types of mutations to be responsive. NICE guidance in the UK outlines its use, typically considered for children and young people under 18, sometimes up to 21, and importantly, during pregnancy. A trial of the drug is needed to see if someone responds.
Okay, so it's an adjunct for some.
Exactly. An adjunct to diet, not usually a replacement.
And managing this requires a whole team, I imagine.
Definitely. A multidisciplinary team is essential. Metabolic specialists, specialist dietitians are key, clinical psychologists for support with the challenges of the diet, and any neurodevelopmental issues, genetic counselors.
Right.
And we absolutely have to mention pregnancy management again. It's critical. Women with PKU need extremely strict dietary control before conception and throughout pregnancy.
To prevent that maternal PKU syndrome in the baby.
Precisely. Keeping maternal blood phenylalanine levels very low protects the fetus. Sapropterin might also be used during pregnancy in responders to help achieve those targets.
Okay. And is treatment still worthwhile if someone is diagnosed much later, maybe already has some intellectual disability?
Yes, evidence suggests that even later diagnosis and starting dietary treatment can still offer benefits. It might improve behavior, attention, maybe prevent further decline, even if it can't reverse existing structural brain damage. So it's generally considered worthwhile.
Good to know. So if diagnosis is early and management is consistent, what's the long-term outlook, the prognosis?
With early diagnosis, typically through newborn screening and good adherence to the diet from infancy, the prognosis is actually very good.
Really?
Yes, individuals can expect to have normal intelligence, or very near normal. They can go to university, have careers, families, lead essentially normal lives. Cognitive impairment is largely preventable.
That's fantastic. It really shows the power of that early detection and intervention.
It's a real success story of newborn screening and metabolic medicine. It prevents profound disability. And, as we said, careful management during pregnancy means women with PKU can have healthy children too.
That's incredibly positive. But just to round things off, what are the potential problems if things do go wrong, if it's not managed well? The complications?
Well, the consequences of untreated or poorly managed PKU can be severe, as we've touched upon. Neurologically, the biggest concern is irreversible intellectual disability.
Right.
Seizures, tremors, movement disorders like spasticity or ataxia can also occur. Behaviorally and psychiatrically, you see higher rates of ADHD, anxiety, depression, mood disorders, sometimes difficulties with social interaction.
Okay.
Developmentally, untreated PKU can lead to poor growth, sometimes microcephaly, small head size, and potentially issues with bone health later on.
And the maternal PKU risk.
And the huge risks of maternal PKU syndrome for the baby if the mother's levels aren't controlled during pregnancy, intellectual disability, microcephaly, heart defects in the child. It really highlights why lifelong management and careful pregnancy planning are so vital. Preventing these complications is the whole goal.
Absolutely. Okay, so to quickly wrap up our deep dive on PKU, we've seen that it's this inherited autosomal recessive condition. Problem with the PAH enzyme leading to phenylalanine buildup. Newborn screening is the absolute key for early detection. Management is primarily that lifelong, tough but effective low phenylalanine diet, sometimes helped by sapropterin for responders.
That's the core of it.
And untreated, the complications, especially neurological, can be really significant. But with good management, the outlook is generally excellent. And remember, our mnemonic, PKU, poor kids, metabolize unsuccessfully.
A good summary. It really does underscore how understanding the biochemistry and intervening early can make such a difference.
Definitely. So for you listening, hopefully that gives you a solid framework for PKU revision. Go back over the key points, use the mnemonic if it helps. And if you're looking for more resources, practice questions, things like that, do check out passthemsra.com and freemsra.com.
Great resources for revision, yeah.
Loads of useful stuff there. Thanks for joining us on this deep dive.